Okay, I think we'll go ahead and get started. Welcome and thank you all for coming. This is the 26th annual Garbos Lecture. This lectureship is supported by the Garbos family in honor of their daughter, Emily Cara Garbos. She was born with pentology of Contrell. This is a rare midline defect, and it included a couple cardiac defects, including ectopia cordis, which is where the heart is located outside the body, and tetralogy of Fallot. So sadly, at that time, Emily did not live long after birth, but in her memory, the Garbos family did establish this lectureship, and they do remain committed to supporting education and research in congenital heart disease here at Children's National Medical Center. So along with Dr. Brule, Dr. Jonas, and the Children's National Heart Institute, it's my pleasure to introduce our speaker, Dr. Elkanan Bruckheimer. He is the Director of Pediatric Cardiac Catheterization and an attending pediatric cardiologist at the Schneider Children's Medical Center in Israel. He graduated from University College, the Middlesex Hospital Medical School of London University in England, completed his pediatric residency in Jerusalem, Israel, and then he completed his Pediatric Cardiology Fellowship at Yale University School of Medicine here in the United States. And then after he returned to Israel to begin his practice, he has been there since, and he became Director of Cardiac Catheterization there in 2003. So over the last 15 years, Dr. Bruckheimer has become a proven innovator and entrepreneur in cardiac interventions. He holds 3 patents. He consults for a number of biomedical companies. He's a leading expert on 3-dimensional cardiac imaging. He is also the medical director at Real View Imaging, which is developing real-time 3D holograms to enhance medical interventions. He'll speak about that today. He's authored over 50 peer-reviewed articles, given over 100 international presentations, and been faculty for over 80 meetings, so quite accomplished. So please join me in welcoming Dr. Bruckheimer for the 26th annual Cara Garbos Lectureship for his talk entitled Innovations in Pediatric Cardiac Catheterization, How I Met Forssman, Abernethy, and Gabor. Dr. Bruckheimer.
Well, thanks very much. And it's the first time ever I'm giving grand rounds, and the word grand sounds too much for me. It's a big honor, and I thank Charlie and Chris and the Garbos family and all of you for turning up this morning. So when I was putting this lecture together, I wanted to choose something, instead of like sort of giving some sort of academic, we've done 20 of these, and 3 died, and 3 didn't, and the rest we don't know about, and those types of lectures. What I wanted to do was I wanted to sort of look at, let's say, what happened with me with pediatrics, and why I think that pediatrics is a very good place to innovate and to do things which are special. And so I just chose these 3 names, Forssman, Abernethy, and Gabor, which is Forssman was the first person to cath, we'll discuss in a second. Abernethy because of the congenital portosystemic shunts, and Gabor, who invented holography. And I've tried to put this lecture together, in fact, 2 lectures which I've put together. And over the next 45 minutes or so, I hope to impress upon you that being pediatricians, we are totally and utterly blessed, because when you make a change in something, it's for life. Kids generally have one problem, and if you define that problem well enough and you think about how you want to solve it, you can do a lot of good. And I think that you don't have to be a researcher. You don't have to, stick your nose in gels the whole day, or just with percussion, palpation, a little bit of thought, and a little bit of imaging, you can do great things. So without further ado, let me see, that was sort of my gestalt when I put this lecture together. And I'm very happy if I say something and somebody doesn't understand or someone disagrees, just interrupt me and tell me. This is not like, the Torah coming out of Zion. This is, just say, hey, can you say that again? I'm not quite clear about that. Okay? Good, thanks. Okay. So, is this working? Okay, so this is probably one of the most important pictures ever created in Google Images. It's Werner Forssmann himself, who cast himself in 1929. He thought it would be a good idea to cath, and we can get a lot of information by putting catheters in the heart. We just didn't have these, like, I don't even think they had rubber then, they had Bakelite, and he was using like a urinary catheter. And they were very concerned that if you advance catheters, they didn't have guide wires and that type of stuff. If you advance it, you'd damage yourself. So he managed to convince a nurse to help him. He did a cut down because he didn't have cells in his technique, and advanced the catheter. He was obviously right-handed, and did the cut down in his left antecubital vein. And he advanced the catheter here and then walked to the, he got to his right ventricle, and I think he had some VPVs, and he was there. And then he just went to the X-ray room and injected iodine, and we can see the catheter getting hit. And he did that, and he did one other cath or something, and then he was sort of discouraged, and he went to be a urological surgeon, and he got the Nobel Prize in 1956 for inventing cath. Then it was really easy to get a Nobel Prize. So anyway, he got it with Cornand and who followed his technique. But he went with what he thought was interesting, and then over the last 80 years, the cath lab has changed, become a place of multiple interventions, combining with surgery, lots of imaging, lots of screens, a very, very interesting place. And now we can treat so many things which are not cardiac. We cath the brain, we cath the heart, we cath the liver, we cath cancer. And certainly image-guided interventions is going to be the future. And I wanted to just take the first 20 minutes of this talk or so just to look at some things that we've done with pediatrics, which weren't necessarily things that we say, oh, we could do that, and because of people thinking. So first of all, when I say to people, like people say, like, what do you do? And I say, I cath kids. And they go like, why? They have coronary artery disease? So I said, no. And the big difference, I think, between congenital and adult heart disease is that we're born with normal hearts, we screw them up as we go along. And kids are born with abnormal structures. And that's the big difference. And so while we were dealing with abnormal structures, abnormal physiology, abnormal function, where we had problems with reduced systemic perfusion, but there's no aortic valve, or there's no pulmonary valve, that the adults don't have that issue. It's changed a little bit now. We meet up a lot with heart failure and arrhythmias, and they've moved away from coronary disease. Now we have this structural disease, which has become a very, very, very fruitful relationship between us and the adults. And when I got to Schneider in 1998, so we were doing just under 200 procedures, and last year we did 1,539 procedures. And it's not because they closed every cath lab down, which is what I think it would, but that's not the reason. It's just because we're doing more and more and more and more different things. We're bringing cancer into the cath lab, vascular access, complex vascular access into the cath lab, interventional radiology into the cath lab, much more aggressive way in pediatrics. And so I tried to take a couple of examples of things which I think show how you can sort of stretch the imagination and then go forward and forward and forward. So this is a muscular VSD. Muscular VSD, here's the left ventricle, here's the right ventricle, here's the septum. Somebody's taken a piece of that state. And so with the catheter in this 6-kilo baby, the catheter looking from the lateral side is in the left ventricle, and you can see that the contrast goes into the right ventricle, and that's a muscular VSD. So you can take the approach of surgery and so on. So Amplatzer invented the Amplatzer device. Before that, Forssmann was doing a lot of work with clamshell devices. And trying to find something that you could fold up very small or remember to be big. So you can either do that mechanically or by shape memory alloys with nitinol, which is now very accepted. And you can do the same approach with general anesthesia, so the patient's asleep. You image with transesophageal echo. You get an axis where you want to go, the femoral vein, bitemporal jugular vein, and femoral artery. And the approach can be a number of approaches. We'll look at 2 of them. And we've also, if they've had a band because you couldn't close multiple VSDs, Swiss cheese VSDs, so you can dilate the band if they have the band. So here we can see again the muscular VSD. And then just because we can, in the heart, do what we want to do, because there's so many ways of going across. You can go from the IVC to the right atrium, across the PFO, or make a PFO, go into the left atrium, across the mitral valve, across the VSD, and back up to the pulmonary artery, a vena-venous loop transectomy. And then you can take the sheath there. And because these shape memory alloys, you can squash them up and put them into small catheters. You can fold it up and they can come out big. And so that way, you just close a VSD very nicely on a 5-6 kilo baby at the age of 5 or 6 months. We can do AV loops in the sense of, you don't know, it's very, like VSDs are this way on the left ventricle and they look like this from the right ventricle, it's trabeculated. So they're easy to cross from the left side, but you don't want to put large systems into small arteries. So you create loops. So you can get across the VSD. You can grab the wire on the other side, and then you can exteriorize the wire. And then you can follow that wire like Hansel and Gretel through the forest, and then go up and put the VSD device in and so on. So the use of getting in there from different positions and folding things up small and closing holes in the heart, everybody does it. They probably do it here over 100 times a year, VSDs and ASDs and PDAs and that type of thing. So we have these devices. So I got a phone call many years ago. Someone said, we can't get the kid off the ventilator. And do you think you can put a 5-kilo kid, 4-kilo kid after transposition, had left main bronchus, which was included, and said, do you think you can do something with that? I said, well, the silicon stents and all this type of thing, the major issue. I do know how to cath. So if you want, I can put a metallic stent inside the bronchus. And then I thought, okay, how are we going to cath the bronchus? Because I don't know bronchoscopy and I don't know ENT, but I do know how to cath. So what I decided to do was set up a mechanical way. It's just a parallel way to mechanical ventilation. I don't want to I wanted to put a sheath, like I put it into the femoral vein. I want to put it in the trachea. I don't want to cath through that. And I thought then that if you have a separate system, instead of using a rigid bronchoscope, so what I could do is if I have a separate system, then if anything goes wrong, I can take my system out and they can ventilate through that. If there's a big bleed, if there's a perforation, if there's anything done. And then I'm going to use standard catheter techniques. I'm going to use fluoroscopy, I'm going to use balloons, catheters, contrast, and everything. And the other thing is because I have a parallel, so they can bronch through there, and we can check each other. And then we saw we could do anything. We could do balloon dilatation, we could do stent implantation, we could do retrievals, and we could even close bronchopleural fistulae. So the preparation is the old cath lab. We were much younger then. And here, we put a tube in, and then I just give the anesthesiologist my sheath. So this is a kid with a tracheostomy, so we're cathing through here's the flexible bronchoscope through the trach, and here's my sheath in his mouth, or going in parallel through the mouth, where the patient had an ET tube put in, and we're cathing through this. And then simply had a stent in there, and there's granulation tissue, and we ballooned it, put another stent in, and same as I was doing the pulmonary arch. So then I get a call and they say, well, I understand you're doing respiratory work and doing stents and all these different types of things in the respiratory tract. So I said, yeah. So we've got a 62-year-old lady, she had a pneumonectomy, and it's broken down. They took off, because of cancer, they took off her left lung, her right lung, sorry, and it's broken down. Is there anything you can do? Because they don't want to go back in, and she's going to live for another year and a half or so, and she's just got air coming out the whole time, she can't get home. So the only thing we can do is if they want to do Amplatzer devices, we close VSDs and ASDs with, we can cath it through the mouth, and we can do that. So here we can see that this is the stump, it's been cut off, and there's some dribbling through it, and this is her chest. So we went through the mouth, as I showed beforehand, with a double barrel system. So they could do their bronch, and we could have our system, and the wire goes across the fistula. And then once we're across, put the sheath in, and as we inject contrast, this is her chest. And then we can just put an Amplatzer device in there. And as soon as the Amplatzer here, you can see we could put it through this tunnel. And the nice thing is the disc, let's say a 4 or 5 millimeter ASD device, is about 16 millimeters. So it covers very nicely, circumferentially, the whole of the fistula. And then we started doing this quite a lot. We've now done about 40 patients. And we published it. And here you can see the fistula and the proline sutures that have broken down. Here's the fistula. And here's the Amplatzer device, and 2 weeks later, completely granulated over. So this is like off label, and just using technique and having fun. But it does a lot of good for patients. And it's all like lateral thinking and a little bit out of the box. So then when this kid came in, he'd aspirated an open safety pin into his lung. So they said, well, you do interventions. What would you do with this? Like a challenge. And I said, no problem, I'll go and take it out. And they said, well, you can't take it out because it's open and it's reversed. So I said, you don't understand. I'm going to go in, I'm going to close it, and I'm going to take it out. They said, you can't do that. I said, okay. So it took 3 days of convincing. But so here we have parallel systems. So here they are with the bronch, and here I put a cobbler catheter down. And I went behind it. And so here's the cobbler catheter, and we just get with a 5 millimeter snare behind it. And you can see that you can move it a little bit. But then, that was on the lateral, but once we got there, so here we could grab it, and then you can, by slowly opening the snare, you can, like that's just going behind your elbow and then open and closing the elbow. So we could manage to close that. And here you can see that in about 5 minutes we had it closed. But then the problem is how are you going to take it out? Because if you grab it again, you may open it. So then what we did was we brought down a sheet, a long sheet, and just put an 8-French sheet, which here, just a corrosion wire, which has a little bit of a J behind it. And then you can just take it out. So that was much better than doing a lobectomy. For some reason, my picture has disappeared here. I don't know why. So I was doing all these things and just using equipment that I had to try and solve problems that were presented to me. And then I turned up in a conference, and I invented an IVC filter. So I had to go to an IR conference to present it. And they were showing interesting cases. One of the interesting cases they were showing was that we don't know what this is. It was a 9-year-old girl, and she has a vein going through her liver. And I was sitting at the back, ready to present. And they were all discussing it, the IR guys. And I stood up at the back and said, hi, I'm Alfred Brookheimer. I do pediatric cath, and I think that's patent ductus venosus and Abernethy. And they go, oh, yeah? And I said, yeah, I think that's what it is. And they said, what do you do with it? Well, I said, well, it's not good because it's like a tip. This is a hyperammonemia, so you can close it. And they said, well, how do you close it? Because it's very big. So I said, you can put stents in it, you can tie the stent, you can put something inside of whatever. So I'll show you. So I did that case, and then this was considered like a really rare disease. But somebody heard, Israel's like it's like 9 million people that all live in one village. So somebody heard that I closed the patent ductus venosus, and it dribbled through to the gynecologist, and they had a fetal case. So I said, what do we do with it? And so they came to me, and I said, well, you know, why don't we wait and see? Then I started getting more and more of these consultations. And the thing is that this is a very difficult thing to treat, because if you have a patent ductus venosus, what happens is that if I go forward one, we know that the ductus venosus, its job is to take blood from the UV and to bypass the liver and to get it to go into the heart. But that's not true. If you take a placenta, okay, the placenta has 2 arteries going towards it, and it has a vein which drains it. So it's an AVM, because it's a low-resistance circuit, because it has to be. I mean, if it's a high-resistance circuit, then it'll be very difficult for the fetal heart to work against it. It's a low-resistance circuit. Now, we know that because when you don't have a ductus venosus, one of the things you get is you get fetal cardiomegaly, high drops, and you can lose the kid. So what the ductus venosus does is it has 2 jobs. It's a sphincter of the placenta, and it's a director of blood. It says, some of you will go this way, and some of you will go that way. And that's what it does. It's like a very clever traffic policeman. Now, the trouble is, if it's a duty, and everyone goes this way, nothing goes into the liver. And if nothing goes into the liver, then the portal veins do not develop. And if the portal veins don't develop, if you come to close it, then there's nowhere for the blood from the gut to go, and you get portal hypertension. So, which is what Abernethy, I don't know why his picture has disappeared from here, described. And what you get is you get this bypass of the splenic vein and the supramesenteric vein, joining a vein, which is by the Abernethy malformation, bypassing the liver. And this, so if you came here, there's nothing going into here, and there's no egress from the gut. And you can see as we inject here that the portal venous system has not developed. So I thought, okay, and there's all different types. I mean, here we inject in digital subtraction angiography into the SMA. So we're filling the whole of the gut. And you can see that the SMV comes up here, and the splenic vein comes up here. And here you can see a portal system that, as I let that play, you can see that there's also an aberrant vein which drains it to the splenic vein and then into the renal vein. So this patient has another type of portal systemic shunt. A portal systemic shunt can be intrahepatic as well. So here again, we're once injecting into the SMA. And you can see that the blood just goes. There is a portal system, but there's a big shunt from it. And even intrahepatic can present the same issue of having a shunt with no portal system that has developed because the blood's been bypassed. So the issue was then if you have no portal system and you can't close this, and the kids can develop hepatopulmonary syndrome, or they have problems with hyperammonemia, and they can have hepatomas and adenomas and hepatocellular carcinoma and everything. So if you can't close it and you can't leave it, then you have to get rid of the liver. So we're sending the kids to liver transplantation. So I said, why don't we create a ductus venosus? So this is a patient with hepatic pulmonary syndrome with a saturation of 74%. Very bad candidate at the age of 4 for a liver transplant. and this is his Abernethy. So he's just pouring blood and there's no portal system filling passively. So we decided that what we need to do is we need to make a sphincter that's going to let some blood come through, but push some blood into the liver. And then maybe, with the plasticity of the portal system, it's going to grow. So how do you do that? So we took a stent and we blew it up. This was 16 millimeters. And we just said, let's put it to 8 millimeters. Let's make it half the size. Raise the portal pressure a little bit. So I blew up the balloon to 16 millimeters. I put a suture around it. And then crimped that onto an 8 millimeter balloon. And then I tied the stent, the suture at 8 millimeters on the balloon. Then took the balloon out and crimped that onto a 16 millimeter balloon. Put that through an 11 French sheath from the IJ. And then when what happens is, as you open it up, you've constricted, so you made a band in the middle of it. So you've banded now, internally, that vessel. And when we inject, you can see that little vessels now fill. Now the idea was, we'll get it up to 18 millimeters of mercury. And that'll push blood into the liver. And if it's too high and the kid doesn't do well, we can always take a high-pressure balloon and break the suture and then go to a liver transplant. So we did that. And then, 6 months later, the saturation started climbing quite fast. And he had normal saturations after about 2 months. So this is what he looked like beforehand. And just by putting that device in there, okay, you can now see that he developed a portal system. And this totally resolved. And then afterwards, we just went down and we just put an amplats plug and totally occluded the done. And then we get more kids. Now the kids are coming smaller because people discover them from fetal. So this is the kid that had the intrahepatic one with the portal system. So when we occluded that and we injected, we could see that the patient had a number of different drainage. So by putting a balloon up, we could see that he has a minuscule portal system, like these are 0.1 millimeters. Now I can't put a big stent in there and try and, there's no way in this like 6-7 kilo baby that I can do this type of thing. And puncturing the liver from the outside to do it wouldn't be good because we would tear the capsule. We wouldn't be able to close it. So what we did was we said, well, we have this. So why don't we make it this? So we made a double barrel technique. So we put in 2 stents. And then the 2 stents will reduce the size and then we can close one of them. So that's what we did. And we put the 2 stents in. But when I injected, the computer's going slowly, so bear with me. Just unavailable. When I put the 2 stents in, see if this one works. I'll give it a second to work. I think too much on the computer to do WebEx, listen to me, and that's totally crashing. One second, let's try it this way. So here you can see, sorry to do that, but it's not working on the presentation mode. You can see just by putting those 2 stents in, before I occluded one of them, that we already see a portal system beginning to fill. So using that approach, here we inject again in the SMA on that kid a couple of months later, and you can see the 2 stents here. And what were minuscule, tiny portal vessels have now become a normal portal system. So I think by defining the issues and saying, what do we need and what does this do? You don't have to, I mean, liver transplant sounds really sexy and all the molecular stuff and everything and do this and give that. But it's just a pure hydrostatic or hemodynamic phenomenon. There's a lack of this, there's a lack of that. So just take what you got and build it. And it's something that can be done. So we published this and it's all very nice. So let's move along a little bit. So I'll try again. Let's see now if our computer has caught up with us. So a lot of people think that imaging is, you know, you can do these great CTs and get these beautiful reconstructions. So this is a 16-year-old patient after having a coarctation repair, and he maybe has a little bit of rough and ready area here and mild recoarctation. So they asked me to cath him and just to see what the pressures were. And this we did just as a general lateral. And I think most people looking at this would say, well, this is a nice lateral. So it's a little bit of rough and ready there. It looks very much like the CT. However, when we did rotational angiography, you can see there's a cauliflower aneurysm sitting there and there's a significant coarctation. And I think that the thing about imaging in the cath lab is you can see what you can see, but you don't know what you can't see. And about 10 years ago, when we opened up the interventional radiology service, I convinced my hospital that I think we need to have 3D rotational angiography because we want to do neuro stuff. And neuro, they like doing 3D rotational. And they said, yeah, does it have any cardiac things? I don't know. So I asked Philips to put one in, and apparently we were the first people in the world to buy from Philips 3D RA for a cardiac cath lab. And so when we started using it, we asked Philips what their protocols are, and so we have no idea. So we started making it up as we went along, and we just injected, instead of injecting, let's say, cc per kilo, we do 1.5 cc per kilo. It goes over 4 seconds. And you get these very nice angiographies, and so we got that, and we put a covered stent in, and we could shape the covered stent. And you can see now on the rotation that we got rid of the aneurysm and there's no real calcification. But then we started saying, well, instead of doing 3 injections for a Glenn, maybe this would be very useful for Glens. So, come on. So here you can see, doing rotational angiography on a Glenn, so we're injecting the SVT, you can see that the right, or where the main pulmonary artery stump is and the left pulmonary artery, there's a big difference between them. But then it gives you immediate reconstruction on the thing. But then look how good the reconstruction is, because you can get a head-down view of the volume that you're injecting. You can see there's in fact a severe narrowing here, And then you can plan your stenting. So see how nicely you can see your stent here now, but see how beautifully you see it from a head-down view, which cannot be achieved with the camera. So now, for the last 10 years, we've used 3D rotational angiography, not for coax anymore, it's not special with an aneurysm we look for it. But we use all our Glens with 3D rotational angiography. And then we used it now for doing implantations of pulmonary valves. Because here, the problem with the pulmonary valve is when you put it in, this is a patient who's tragic fellow or Ross, I think that's the patient I think had a Ross, and has a homograft here in the right ventricular outflow tap, which is constricted. The trouble is, there's no problem putting in a stent and opening that up. That's not a problem. The problem is what's next to it. Because if I just move my hand, if I hit this, now if this was a coronary artery, which it very well be, and you crush that, the patient will die on the table or do very badly. And normally it takes too long to do anything good about it. You see how beautifully it is now. If you put a balloon inside that, and it gives you an inner cast of it, and you can inject at the same time inside the coronary artery. I don't even have to stretch it. You can see that this is a long way away by spinning it around. And we do this now. This is our standard practice for the melodies. And whenever we want to put in a melody valve or transcatheter pulmonary valve, we will do that. And you see how nicely you can play with it on the workstation. And you can cut the balloon, you can see the distances and so on. And this is what I call interventional imaging. Instead of doing like CT, which is very passive, you can choose your angle, you can change the anatomy, you can blow up the balloon, you can stretch, you can inject. We'll use this for everything. So I was doing all this work in 3D, and we have 3D TE, and we have 3D EP, and everything. And then this guy walks into my, where is my, okay. This guy walks into my clinic. I was doing Pediatric in the evenings, because I work in the public sector, and in Israel, they don't make, something's gone really wrong with this computer. I'm sorry. Something's gone terribly wrong with this computer. I'm going to close this, and we'll try again. So he came into my clinic in about, here he goes, stop there, great. So he came into my clinic in the evening, and I'm just find general pediatrics, you know, ears and this type of thing, and breastfeeding and so on. I mean, it's very important, but I find it a little bit boring at 9 o'clock in the evening. So he comes in to pick up like some, you know, cream for his kid's rash or something. I think I put this on twice a day after meals, and anyway. So I said, Aviad, what are you doing these days? He said, oh, I'm interested you. He said, we want to make holograms that float in the air that you can interact with them. So I said, why don't you come down to my lab? He goes, why? So I'm doing everything in 3D. I've got 3D rotational angiography. We like 3D before that. We've got 3D TE, we've got 3D EP, and we're doing everything 3D. Why don't you come down and see what we're doing with 3D, and then see if you need holography? So he said to me, you know, we are working with other doctors. I said, come down, have a look. And that's when I became the medical director of Review Imaging. And so you've seen 3D rotational angiography, and you're very familiar, probably, with 3D TE. But what you're seeing is you're seeing everything held in a 2D screen. But you have all that 3D information. So why does all that 3D information have to be held inside a 2D screen? Imagine you could take the 2D screen and you could just get all that information, come out of the 3D screen, and just hold it in the palm of your hand, here. And you can interact with it. And then if you have that information, okay, maybe you could put that information back inside the body, and you can make the body see through. So we tried to do this using an ultimate 3D visualization, and having all the volume of information, all the box cells that you have in real time, okay, floating in the air, and trying to implant it back into the patient. So I'm going to spend the next 20 minutes or so showing you how we're experimenting and developing clinical and medical holography. So we've met Forssman in the cath lab, we met Abernethy in the liver, and now Gabor. Okay, so this is Dennis Gabor. Dennis Gabor, he invented holography, and he said a very famous phrase. He says that futures cannot be predicted, but futures can be created. And he invented holography by using photographic plates. So he said that you have an object, and you shine coherent light on that object, and that light is reflected off, and I can capture that light on a photographic plate to make an interference pattern. And if I shine the same light on the interference pattern, I will get the object printed in light here. Okay, and that's standard holography. And the beauty of holography is that it's the only way to really see 3D with true depth perception. Because you've all seen 3D movies, I presume, and HoloLens and all these different types of things. They use stereoscopy. When we look at something, we have two eyes. We have a nose in the middle. So what we look at, we get slightly two different angles from it. And that's called stereoscopy. And we use those two angles to understand much better the depth, the distance we are and where that is in a position. Pigeons, for instance, they do like this with their head because they have an eye on the side of the head, so they use parallax depth perception. They're looking at my finger twice, and from that they remember the previous one, and that's how they can pick up the breadcrumb, because they can work out the depth by getting two images and fusing them together. But when we see things, so when you see things like a horror movie, and you see 3D and you're wearing the glasses, or it's auto-stereoscopic and you don't need the glasses, what they're doing is they're giving you two pictures, which are on the screen, and they fuse them at some point. And you look at that point, and you fuse those images, and that gives you an optical illusion of 3D. However, it's not really there. You're focusing distally, but you're seeing proximally. If you touch that, try and touch that image, try and reach out to the 3D whatever it is, okay? A person jumping towards you, want to touch Spider-Man or something. Spider-Man will disappear because you're looking at your finger. And you don't have to do this, but you're looking at me now, I presume. So if you look at your finger, I will disappear. I'm going to disappear another 20 minutes, don't worry. But I will disappear because you're focusing, because you can't focus in two planes. Now, when you focus locus, proximally, at about 45 centimeters, your eye can differentiate about 20 different focal planes. If you try and say something which is distant, like in HoloLens, which is 2 meters away from you, and you bring it close, and it's in a single focal plane, and that is distant from you, and you're bringing your finger here, that mismatch will cause you to become nauseous. And that's why, if you really want something here, you have to print it in light, all those focal planes. Okay? You have to actually build all the positions properly, and then you can interact with it, and you can see and you appreciate it for a long period of time without getting sick. So, using photographic plates and doing that long procedure is something which is not easy to do in real time. It's impossible. Trying to create the interference patterns by getting all the XYZ data from the MRI, from the TEE, and printing in light is not easy, and people told us it was impossible, and that's what real view imaging, by a number of different techniques and so on, has managed to do. So we call this the digital light shaping technology. So we take all the XYZ acquired data in real time, and we can print it in light, and it floats in front of you. So here, this is just a slide explaining this vergence accommodation conflict. It's nausea when you feel that you're seeing something which is stereoscopic and you're trying to work up close because the focal plane is in a different position from the convergence plane, and you're working up close, your brain doesn't like it. So even though HoloLens is a fantastic technology and 3D movies are good fun, if you want to bring them into the clinical arena to make it useful, that I'm doing a TEE, I want to see the mitral valve floating in the air, and I want to direct my catheters, I want to do ET, it's not useful in that sense. And this is just explaining that again, that there's a single focal plane, and you can gesture. You can get it bigger, you can get it smaller, you can move it, you can bring things forward because there's something monitoring your gestures, but you can't touch it. And what real view are doing with holography is by creating the hologram here, you can actually touch it. So just to reiterate, what we're doing is we're taking all the 3Ds that we have, so the 3D RATE, EP, and so on, and just pushing it through the system to create holograms which are floating in the air, which I can interact with or put inside the patient. And the type of things we're using it for, there's no point making a technology that nobody's going to use. The type of things we want to use it for is now, instead of using it in the adult and pediatric cardiology, is we're very good at navigating in the heart. They're not that good at navigating in the heart. It's used for them, working in free 3D space, trying to catch things as they move, the anterior leaflet of the mitral valve, the posterior leaflet of the mitral valve, bring them together with a mitral clip. When you're working 70 centimeters away in the groin, and trying to build this from 2 3D planes, makes it very difficult. That's why the procedures are long. So we're looking at AV valve interventions from mitral and tricuspid valve, left atrial appendage, TAVI intervention. So we're doing complete, nice, continuous and contiguous ablation lines for pulmonary venous ablation. And obviously, if we can ever get to the fact where we put a hologram inside the patient, we can do interventional oncology by making the patient see through. So this is trying to show that this is a 2D picture on this is a 3D picture on a 2D screen, okay? And this is the 3D object. Now you can see that when you focus on the, this is now in focus, and this is out of focus. As I bring this into focus, this becomes out of focus as I move the camera lens that I'm doing it. But with a hologram, because it's actually there, okay, it's always going to be in focus as I move it. So as I bring the hologram out of the screen, okay, you can see how detailed it is. And it's always in focus because it's a real object that's coming closer and closer. It's the same as I'm moving my hand here. It's not there or here. It's throughout. And you can see this now, this piece of machinery is now floating in the palm of my hand. And you can move it, and you can rotate it, and you can slice it, and so on. So having holography and bringing it into the cath lab has to be something that's very, very useful, something which is very easy to use. Now, we're always upping the ante on medicine by trying to do more and more complex things, as I said before, in like free 3D space. And we use an enormous amount of 3D imaging, but we trap it inside 2D screens. So it doesn't matter whether we're doing it for fetal work, whether it's extremely beautiful CT angio imaging, or it's 3D TE or electrophysiological data. So we have this high quality volumetric 3D, and what we're doing is giving the display in the interface. Now, people will stand up and say, yeah, well, we can do 3D medical printing. And 3D medical printing is a great thing. You can actually see the patient's anatomy as it is, outside the patient's body, without touching the patient. And you can interact with it, you can understand it. But it comes from CT generally, and it's static. You have to use segmentation, it's very subjective, time-consuming. You have to use your software to create STL files. And at the end of the day, you get a static, rigid approximation of the 3D anatomy, and you can't manipulate it. Because if you want to slice into it, you have to destroy it. You can only do one. And it's restricted to procedure planning, and does that mean that's representative? Is that the size of the heart at the same time? Does it represent the fluid status? So 3D printing is good, but it's not the total answer. And in the modern interventional suite, we're totally reliant on imaging. And we use volumetric visualization of the complex anatomy. And we have to navigate. And our device tissue interaction is extremely important. The other thing is the operator is totally dependent on the guide that's being at 3D TE. Now, I can say go up, go down, go back, go forward. I can do all those types of things. But what's my forwards to his forwards? What's my 2 o'clock to his 2 o'clock? So I'm not independent with my image. And communication is an issue. So this is what RealView have invented. This is the holoscope eye. So here we have this above the doctor. The doctor could be doing surgery or could be cathing, and this floats in front of him. The idea is because it's digital, you can be able to not only visualize, but to interact with things you do with your iPhone, to rotate, to slice, to mark, to measure. And so this is the first ever computer-generated hologram in 2013 in my lab. It's an ASD. So here you can see the ASD. And this is the first prototype we brought out. The machine looks different now. And you can see the heart beating in real time in the ASD and the SVC up here. And you can see the borders of this ASD. You'll put your finger inside the hole. Now, do appreciate you're seeing a hologram on a 2D screen, so it's difficult. We can rotate it. We can see the heart from different angles, from the left side, from the right side. Here's the Amplatter device. You can see how beautifully you can see the relationship between that, the anterior leaflet and posterior leaflet of the mitral valve. you can hold the heart literally beating in the palm of your hand. So we did our first in-human clinical trials. We did that with Philips. This is me and my team, and RealView team with Philips. And then we started taking data from other places. And so this is a core valve used for TAVI, aortic valve implantation. And this is a CT of a patient's aorta. And this company, FIOPS, using finite element analysis, have been able to approximate to a very, very high degree what it's going to look like when the core valve opens in this anatomy by using the different aspects of the mechanics of the aortic valve and the calcifications. And so we have this 3D data, which is moving now dynamic color in real time. And if I want to see a specific thing, I can slice into that and see what's happening as the valve opens and how it's moving the valve leaflets and how the calcification is going to move. So this is a mitral valve. So this is 3D of a mitral valve. Now this valve is floating in the air, and you can see that here I can see the anterior leaflet, and I can rotate this up. I can slice into this, and I can see the approximation of the leaflets one to each other while the heart is beating. I can slice in and slice out to the which part. I can slice in 3 different directions if I want. Now, if I want to say I want to put my clip in a certain position, so I can take my finger and I can point inside the image and I can say I put it here. Now, if you put a point on a screen, on a 2D screen, as you move that around, that point may not be in the right position. But because this is a coordinate floating in the air, as I move this around, that point stays in that absolute coordinate. So if I have absolute coordinates and I have something which is accurate, I could drive a robot. I could do it tele. I could do it I could be here in Washington. I could be doing this in my lab in Israel because I have all the 3D information. And we can do this with Doppler. So we can see Doppler in 3D. We can make this get bigger. We can see where the regurgitant shit here is in orange. And we can rotate it out and see under the valve and make that point exactly where we want it to be, right at the beginning of the regurgitant jet. This is where you want to put your clip. And you can measure distances and so on. So we published this, and people have got very excited. And we've had editorials written about us. And now we're looking, the first machine's coming out in next month. 2 of them are going to Canada, to the Peter Munch Cardiac Center. And we're going to be starting, we've already had 2 clinical trials approved. And we're going to have another clinical trial hopefully approved. We'll start running clinical trials and selling more machines, hopefully. And now we're looking at doing interventional oncology. So imagine a patient had a CT scan, and we need to see inside his body, take a biopsy of his liver, or radiofrequency ablation or microwave ablation of one of the metastases. So here we can, not on the surface of the patient like augmented reality, we can do holographic augmented reality. So to prove this point, and this is just to show you, I'm going to finish up with it. To prove this point, we set up an experiment. This is Charles, by the way, who is the master of holography, who invented the pilot's helmet that are used by the United States Air Force, where the pilot can see everything, and that's under the plane and above the plane and so on, the F-15, the F-16. And he left that project to do this. I have no idea why. Anyway, so he's a very good guy. So anyway, so what we did was, why don't we do that? Why don't we make a setup? We'll take an object and we'll cover it, and we'll try and put a needle in just by using holographic light. So I'll take you to this experiment. So here we have, this is the setup, okay? Looking through the holoscope eye, now holoscope A, tracking the needle, because once the needle goes in through the cloth, you're not going to be able to see it, so you have to make a holographic tracking of the needle. And we put in 3 cameras, so you can see what the hologram person is seeing, what's happening under the sheet, and what's happening from person research from the side. We took 3 test tubes, they're different positions, like a traffic light. And this is what the laparoscopic camera underneath will see. I'm going slowly because the computer will crash. And this is the hologram. And then we took the CAD of the hologram and we registered it on the image. So that's what it looks like holographically. So if we took this image away now, we would see the image as a hologram. Now the issue is once you've done that, is that once you put the needle in, you're not going to be able to see the needle. So how are you going to navigate it? So we track the needle. We have a tracker in the ceiling. So that once we put the hologram on and we register the hologram, when we come into the region of holography, the needle becomes a holographic needle. We track it, we put it exactly where the needle is. You can see wherever we move the needle, it goes there. So now, the test, if you can do that. So we cover the system up. Okay, so we'll cover it up. So now it's covered, put a sheet over it. And so now, this is what the camera sees underneath. And let's look at it from the different angles now. So as we cover it up, we've now put the hologram on this. Now, just as interesting, this looks like 2D, right? But this is in fact 3D, as you will see. So we bring the needle in. So this is what you would normally see in any OR or any cath lab or someone sticking a needle into a patient, looking at an ultrasound, looking at a CT, putting the patient back in, back out, the CT. And we're going for the middle test tube. This is what it looks like, what's happening inside the patient's body. The needle comes in. Come in, needle. Thank you for crashing. And let's see if I can get this to... It's always good when something crashes at the end of your talk. Yeah. Okay. Big build up and a big let down. Okay, let's try without the... So the needle comes in, and as the needle comes in, you can see that you're not scraping around the test tube, you're not missing the test tube, you're not going in and out. It's 100% accurate, straight. So we'll go down a slide. So this is what it looks like when you do it holographically. So we can see the needle come in. The needle is now tracked, it becomes a holographic needle. And then you just place it straight in to the test tube. So if this was metastasis inside the liver, you want to get around the blood vessels and so on, you could do that. And we say we want to go for yellow fluid, we have yellow fluid. Magic. So holography is getting everyone very excited. And everyone very excited. So you've got TED-Med excited, you've got Grey's Anatomy excited. Seriously. If you take their video and you take our video, it's like word for word, verbatim, same thing. So we paid them a fortune. They paid us, and we didn't pay them anything. And Prime Minister was happy, and so was the Japanese Prime Minister was happy. Shah was very happy. And Washington Post was happy. Whatever you politically want to think. We think medical holography is going to just go across the board for dental work, for spine surgery, orthopedic surgery, for cardiac, for electrophysiology, and everything. This is what the system looks like, and you can talk to the system, and you can have a mouse, or you can do it with your hand. Thank you very much indeed. So what I tried to show, thank you very much indeed for this opportunity. So what I tried to show was that I started in the cath lab with Forssmann, and thought, just put catheters into places. Started using different types of equipment, different types of ideas, different approaches. Took that to different arenas. Try to understand the physiology of other different types of things that are going on, like the liver, and imported that. Took different imaging techniques and took it forward. And as I said, nothing here is cellular, nothing here is molecular. And I think you can do that in any aspect of pediatrics. Because kids are small and they live a long time, and they're very have singularized problems generally, I think we can do a lot of good just by giving it a little bit of thought. Thank you.
Thank you. Thanks so much. As a reminder, there'll be a reception on the West Wing 1.5. People want to ask further questions. We'll open up the questions now.
Yeah, very nice talk with all the technology. With the HoloLens, you did like the way it's presented there? Do you feel like you need the holographic view?
So the HoloLens...
To see things, and then will people trust that view, and what do you think is the accuracy of that view?
I think all these technologies are amazing, fine. I think virtual reality is great, augmented reality is great. Depends on what you want to do with it. If you want to be entertained, you can be entertained at 2 meters. When you want to work up close for a long period of time, you need to have it up here. And you could do that if you wore 20 HoloLenses and each of them was giving you a different focal plane, but it would be very heavy, and it would be very expensive. But, you could do that. So I think the HoloLens is very good, like for consumerism, but it's not good for medical. And it's like we're in a niche, and they're in a niche, and they're a stereoscopic solution. And stereoscopic solutions are great fun. I think the World Cup, like it's 3D, but it's going to be fantastic. But it's not going to be useful for pinpointing, because when you try to do accurate interaction, and you try and do it up close, it's just impossible. And it's not a limitation of technology, it's a limitation of the eye. It's just the way we were created. So to have depth perception, and you have to have all the depth cues, and you can't create 20 depth cues in one optical elusive plane. It's an elusive illusion. Sure.
Abernethy malformation as like a use in, say, restricting pulmonary blood flow, like for PA vans using interventional solution instead of surgically?
That's a very good question. I've set up another startup just now called Restore Medical, where there's a very clever guy called Dietmar Schrantz. Some of the people here know him. And I think one of your surgeons worked with Dietmar. So Dietmar's been banding pulmonary arteries for kids with dilated cardiomyopathy. And I had an idea when I was at Yale that we could band the pulmonary arteries for people that have heart failure, because similar to what we're doing like congenital transposition, training ventricles and so on, because of the interventricular septum. So in fact, I'm going to Detroit next month and capping dogs by putting in flow reducers, which I've invented, adjustable flow reducers, into the pulmonary arteries for heart failure. So you're 100% correct. Yeah. I mean, I don't know if it's going to work, because everybody told me they're going to die, because they said, like, adults are not like little kids. I go, oh, duh. And they said that they're, as it says, myocard is totally different. So that's why they can get over their dilated cardiomyopathy for adults with ischemic heart disease. So we're using an ischemic heart disease model in dogs. We did 3 dogs, and they all survived and got better, but it wasn't a controlled study, it was a surgical ban. So now we're going to use this system. It's called Restore Medical, and anyone want to invest, this is the time. But a good idea, you're absolutely right.
And he didn't. You didn't set him up with that question.
I did. Good job.
Good. This was fantastic. Thanks very much. I guess one of the things that is appealing is the potential for fetal intervention using holography, and I think one of the limitations may be the resolution of the 3D imaging in something that's moving, like a fetus or like the heart inside a fetus. Is there something to get over that hurdle?
I mean, there are world experts on fetal intervention, if it's in the heart, Wench works, and so on, enormous amount of work done at Boston. We don't do fetal intervention. I think that the problem with the fetal intervention is that we see it for around about 16 weeks. It happens around about 8 weeks. And so let's say for the hypoplastic left heart, opening up the anterior septum, and a lot of the damage is done. I think there's a lot of complexes, and obviously you could use it for that. Not posterior atrial valves, but I think that fetal intervention hasn't really proven itself. It really makes a difference in the natural history. So let's say like critical aortic stenosis patient with fetal intervention, like Carlos Pedro's done tens and tens and tens of these, and not a lot of them get to biventricular repairs. It's not like I open the valve and so obviously it would help because you have easier navigation and so on. But I think that the truth of fetal interventions, we need to get in earlier to make a true difference to the morphological of the heart. But that's not my field. So.
That was a great presentation, and actually I had the same question, Charlie, or a similar question. Being a 3D visualization enthusiast, when you talk about the utility of your system to be used like in an intervention, what's your temporal resolution? How quickly can you update the hologram if the patient's moving, or like for example, fetal interventions?
Well, you saw the ASD, right? That's real time. That's the same as you see it on the screen. There is no delay. Now, most people work at 512 resolutions, 512, 512 in a single plane, and we can do 1024, 1024 with a refresh rate of 60 hertz in 20 focal planes. So it's like, that is the limitation of the eye. So until the eye gets better, we can match it. We don't crunch any data, but we do manipulate the data. And as we mentioned last night at supper, so for instance, a lot of information is used or supplied by the manufacturers or the vendors to make you appreciate depth. For instance, color and shadowing. But when you actually have it in front of you, you don't need color and shadowing in the same way. So we get rid of color and we do it in grayscale, and that gives you a much better definition. You're not wasting information. And in EP, we can update. We've hooked up to a biosense system, and it just comes out. But we have to choose what data we want to show, and it's an integrated process. But from the point of quality, temporal resolution, everything is 100%. And you can see how we track to the sub-millimeter level with the needle. All these things have been solved. And the interaction is we've worked an enormous, it's very difficult bringing in technology which is extremely complex. And you know, if it's extremely complex, you have to have this huge computer and everything. We've managed to put it into a single system, zero gravity, and your interface with the system is totally natural. Like you just walk into the lab and you say, oscilloscope rotate, it rotates. And that's it. And you just say slide, stop, you slice it with your hand. That's how it is. So I hope people will like it. If they don't like it, we'll close the company, we'll go back to Restore.